Hi, and welcome to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today, the show, we have Jay Baruch. He's an emergency physician. He's the author of the book, Tornado of Life, a doctor's journey through constraints and creativity in the ER. Jay, welcome to the show.
Thank you very much for having me, Kev. It's a real honor to be here.
So we'll get into your book and excerpt in a little bit. First off, briefly share your story and journey to where you are today.
Yeah, it's a little bit of a winding journey. I'm an ER physician. I'm professor of emergency medicine at Brown at Albert Medical School. And I'm going on 30 years of doing emergency medicine work, which can feel like, I think in dog years, it's like 160. My background is I came into medicine through English and writing. I was an English major in college. And with all intention of becoming an English professor and a writer. And an undergraduate, I had the opportunity to take a course or two that involved going to a local hospital and talking to patients. And it provided me a different lens for understanding stories and a way to impact those stories. And it felt so powerful and meaningful to me at that time that I just switching course. I stayed an English major, but I applied to medical school. And my academic interest is actually from bioethics. And I look at bioethics as a high point of a challenging part of a story, and medical humanities. And I'm a writer, and Tornado of Life is my third book and my first book of nonfiction.
So, as an emergency physician, a lot of the cases that you see are relatively short. Sometimes you may never see these patients again. Tell me the intersection of stories in emergency department setting.
I gave a talk years and years ago on the power of story in medicine, and there was this emeritus internal medicine physician. This is a long time ago, who came up to me afterwards, and he's like, I don't get it. Like, you talk about story. I go, yes. He goes, but you're an ER doc. I go, yes. He goes, but you have no time for story. And I knew exactly what he was getting at, and I hear that all the time. But the thing is, Kevin, is that the patients don't stop bringing their stories to the ER. And the fact that we actually have so little time means that we have to bring as many different types of tools to the encounter as we can. And for me, that included actually thinking like a creative writer and how stories evolve and paying attention to language and what's said and what's not said. Because unless we get the story right, the best medicine doesn't work on the wrong story. And some of the biggest, most moral harm that we do to patients is when the stories that they tell us is not the one that we're hearing. And I feel like that's when they feel most disappointed and most unheard.
So, as the emergency department has evolved, you mentioned you've been an emergency physician for 30 years now. There's a lot more constraints that really takes away from the story that you can hear from the patient. So, I guess from your perspective, given all these constraints, whether it's time constraints or bureaucratic obstacles, how do you maintain the focus on each patient's story in the emergency department?
Curiosity. I feel it's like I feel like one of the first impulses that we have as clinicians, and I think it's a good impulse, is like we want to do something. We want to help. And there are so many situations, especially in what I do and what you do, Kevin, is that there is like an identifiable problem. And we have to nail that and respond to it in a timely and an accurate way. But so many of our patients, their problems are so complex, right? It's not just that even the medical problem might be uncertain, might be some sort of non-specific chronic pain that we're still trying to figure out, but they're still in distress. And I feel like sometimes the paradigm in which we look at problems, which is reductionist, gets in the way of us thinking more openly about multiple aspects of an experience. And oftentimes I find with patients that even if I can't give them an answer, just expressing the fact that, listen, I know what you're going through is tough. I don't know how you make it through the day. It's really hard, but you're doing a great job. This is what I can do to move things along. This is what I can't do, but this is what I can do for you. And thinking about not just complaints, but what the patient's needs are. Now, of course, some of those needs can feel infinite and enormous and beyond our control. And I feel like sometimes when we face those overwhelming challenges that we sometimes pull back and instead trying to be curious and bold enough to at least for me, that is what empathy is willing to go to those really challenging spaces that patients want us to go to and at least make a step or two in that direction.
All right, let's talk more about your book and excerpt. Your book is titled Tornado of Life, A Doctor's Journey Through Constraints and Creativity in the ER. Now, before talking about your book, tell me about the events leading up to why you wrote the book in the first place.
The book is actually the end result of just my writing practice. So I've always written, and then most of the time I'm writing for myself. And all the times I write, just figure things out on the page. We get distressed, things happen in what we do, or just emotions that we're feeling. And the written word has always been my way of encountering that, dealing with that, identifying when I'm being too easy on myself. And I also think differently when I'm writing. So this book came out is basically the end result of a lot of these small moments that we don't oftentimes talk about in medicine, especially not in emergency medicine, which sort of the drama and the mayhem gets all the attention, and not these smaller moments which we're facing uncertainty when we're not certain what the right thing to do is, or we have to choose between two options and one of those options is not the best outcome, but we're pressed because of the resource limitations of a situation or an institution or a system. What are the limitations that we don't necessarily pay attention to? And those things we take for granted, Kevin, that are so hard. For me, one of the examples I write about is how we just move on in emergency medicine after a devastating, life-changing event, or how we tell bad news to a family and just move on. And then what's our response to that? And so I try to be an N of one. We
Yeah.
have people who do this great research, clinical trials, multiple institutions. I'm taking people into just me. So this is just one person trying to grapple with some really challenging situations and drawing on my background
Mhm.
in ethics and humanities and writing and literature and narrative and trying to see how those tools help inform my understanding of what we do and perhaps provide a different lens into what we do.
So you mentioned quiet moments, and you're right. That's not something that we normally associate with emergency medicine. Tell us a story. Give us an anecdote or an example of one of those quiet moments that moved the needle either for yourself or for a patient.
One of the pieces I have that always lived with me for a while was a woman who had end stage cancer and one of those people who was in hospice and then dropped out of hospice, like a hospice, someone who dropped like their notice dropped out of hospice
Uh-huh.
and comes in the middle of the night
Huh.
and she won't talk to me, and she won't tell me what's going on and she looks near death. And her story in the chart was like someone who started off really lovely and nice and then became quote unquote difficult, the difficult patient. And she wouldn't tell me what was going on. She refused to even talk to me for the longest time. And in the end, fast forwarding, uh, I recognized, Kevin, that what she wanted, I think, was she was a fighter. A relative was there. She was a fighter. She was a fighter all her life. And I think she wanted one last fight. And when I was in and out of her room throughout the night, what struck me is that all the things we were focusing on up to that point had to do with her disease and her disease course and what was done and what was not done. And what we hadn't done, what I hadn't done, was actually make her the protagonist of her story and
Mm.
honor that. And how I was trying to figure out what exactly this woman wanted and how I can meet her needs. There's a piece that made me rethink about like how we sometimes take patients away from being protagonists in their own story, and we have to put them back into that position.
So how did you go about doing that? How did you make her the protagonist in her own story?
I have this magic wand question, which sometimes I ask patients when I'm confused or trying to figure out what's going on or how I can meet their needs. And the magic wand question is like, if I had a magic wand and I can do anything for you at this moment, what would it be? And I thought that she would say, I wouldn't want to have cancer, but she didn't. And it had to do with the experience of dying. And a lot of it had to do with the fact that the idea of hospice, she was such a fighter, such a tough person and raised her kids and single mom, that she was such a fighter that the way hospice care was framed to her and comfort care to her seemed like giving up. And she wanted to go down fighting is what I expect. And talking to her and talking to her family member that was there. And again, like I go extrapolating this and trying to figure this out. But for me, it became like, how do I meet this person's needs? Because one thing that we assume when people come to the emergency department is that they come for a reason. And I think they do. I think everyone leaves their normal, their quote unquote normal life, even though it might be abnormal and difficult and challenging and sometimes horrific. But to come to the ER is a narrative event. Like it is an event. So there's a reason, there's a motivating force that takes you out of your previous place and takes you into this sometimes chaotic space
Yeah.
of the emergency department and the hospital. And we have to find it.
So after reading your book, what are some of the main messages that you want those readers to come away with?
We focus so much on following the evidence and
Mhm.
guidelines and algorithms, and they are so important. Like we have to provide evidence-based, scientifically proven, recognized, legitimate care. That's how we move science forward. That's what's best for our patients. But sometimes it's at the expense of the fact that we take care of humans.
Mhm.
And every human is different. And we have to allow ourselves to be creative. That's one of the messages that I express in the book. And what does it mean by being creative? It's like having imagination, to think about what could and what should be, to not just think what patients are telling us, but what's between the lines and what's not said. I have a quote in the book from the actor Anna Devere Smith when she says this incredible, powerful line, which I carry with me into every ER shift, which is about we can learn a lot about a person in the moment that language fails them. And the thing is, Kevin, and this is what happens when people say, "Look, what do you do when you teach students or teach residents?" And I think the most important thing I do is just give them permission to be them, like to not necessarily always follow a script. And that a lot of the talents and a lot of the skills, and I think a lot of the meaning that we want from our physicians, we have. Our young people have. We have to just give them permission to be the people that they are and bring all their talents, not just their intelligence and their science smarts, but their talents as musicians and as writers and as artists and as designers or as architects or whatever informs their religious training, whatever it is, there are multiple facets of their being somehow was going to be that thing at a particular time that's going to help them connect with the patient.
So tell us an example of how you would inject that creativity, allowing the other physicians, especially the ones that you teach, allowing them to be them. What would be an example of that in the emergency department?
I think part of it begins with the fact that we're so busy trying to be smart and
Mhm.
having an answer. And I find that sometimes the biggest mistakes that we have is that we're so intent on trying to find an answer that we don't necessarily think about, are we asking the right questions
Mm.
in the first place? So, for example, we had years ago, we had a woman who was a youngish woman with chest pain, and the residents were appropriately so worrying about, is this a PE or is this a heart attack or is a cardiac cause? And and she has a history of anxiety. She said, "'Cause I think it's my anxiety. I feel like we all have anxiety."
Yeah.
I think we all and I was and it's the middle of the night, and she's really oh, I don't like, what makes this young woman come in the middle of the night? And I was sitting there chatting with her, and yes, we had to worry about this chest discomfort and the symptoms she had, but for her, at least, the real issue was the fact that she had switched jobs. She was seeing a therapist or a counselor and did have medications, and she had somehow was unable to get mental health care, and she needed to be put back on her medications. So we were able to give her referrals, we were able to take care of those needs. But the thing is, Kevin, is that if we dealt with only the chest pain and the shortness of breath, and we ruled out the other things, it probably would go down the chart as appropriate care. We did the right
Yeah.
thing. Like we made sure you didn't have a life-threatening emergency. We did all like an objective person would look at this and say, this was good care. Okay. But were there needs that were not met? And did we actually truly help the patient in the long run? Which was the issues behind the symptoms that she was having? And how do you stay open to those possibilities? And how do you stay curious? And I feel like we need to model that. because I feel like so many of us, myself included, like it took me years and years to like trying to finally give up and say, you know what, I'm just going to be myself. And part of that emerged, Kevin, because I realized the things that I was trained for, that scared me, that terrified me, I knew what to do in the end, whether it was a heart attack, whether it was a cardiac arrest, whether it was someone who was difficulty breathing and required an airway. There was an identifiable problem, and I had the skills or the training to go about intervening in some meaningful way. Doesn't mean I wasn't scared, doesn't mean I wasn't apprehensive, but I had a handle on it better than I thought. Those issues and those situations that troubled me the most were those fraught by uncertainty. When I had to battle my own feelings of what do I do? Like this person's frustrating me, and is this person frustrating me because this person truly is frustrating, or it's my response to the situation because they refuse to be an easy story, they refuse to be a question stem for which I have the answer. And as I don't know about you, Kevin, for in my practice, the last number of years, as people have gotten sicker, and the issues are more complicated, and it's medical, like a straightforward medical problem doesn't exist anymore, it feels like to me. And then there's social issues and mental health issues and substance issues and economic woes. And so there's always gonna be something that that we never get rid of uncertainty. And so for me, I used my writing skills and took that to the bedside and thinking a little bit like a science using artist, if I can be so glib. And that I feel I found I was able to respond in a more authentic way. And I was actually able to have conversations with patients that they appreciated because at the end of that is some measure of curiosity.
We're talking to Jay Baruch. He's an emergency physician. He's the author of the book, Tornado of Life, A Doctor's Journey Through Constraints and Creativity in the ER. Jay, what are some take-home messages that you want to share with the Kevin and the audience?
What we do is hard. And it is also, and the things that are so hard about it are some of the very things that we take for granted. We don't think about it as hard. We think about it as this is just what we do. And I feel like we don't allow ourselves to be human. And to be creative, also invites and encourages taking chances. And that means sometimes that we're going to fail. But I feel like that meaning is found in those gestures outward. And I really want my colleagues to be more forgiving of themselves. And for me, at least, too, I've learned to valuing the people around me in a way that I think I always respected them. And I was glad to see certain faces when I show up at work. But I don't know if I truly realized how much I count on them and depend upon them. And so for my nurses, my staff, and the people who make some tough times manageable and bearable, I show gratitude towards them. So forgiveness towards yourself and gratitude for those people around you who you might not realize it, but really help us so much and allow us to do the work that we all want to do and in a meaningful way to serve our patients and our communities.
Jay, thank you so much for sharing your story, time, and insight. And thanks again for being on the show.
I really appreciate it, Kevin. Thank you very much for everything you do.